You can imagine how difficult it was to make the diagnosis of mitral stenosis before we had echo. At that time we used auscultation mainly, and even though in some patients it was quite clear they had the typical findings, also the typical features of mitral stenosis, it was very unclear in others. I'm sure we missed many patients who had the diagnosis of mitral stenosis. I think the potential to make the diagnosis in MS was one of the key factors that led to the development of the technologies we have today. Many people at that time had big doubts that echo would ever make it. So I think the potential to make a diagnosis was one of the key factors or driving factors that we have echocardiography today. But now we should take a look at what modern machines are able to show us in patients with mitral stenosis. So the hallmark of mitral stenosis is doming of the mitral valve. But what is doming? How is it defined? And why does it occur? Well, the definition is diastolic bulging of the anterior mitral valve leaflet. So we're only talking about the anterior leaflet and not the posterior leaflet. Why does it occur? Simply because we have commissurial fusion and the blood kind of gets caught in the mitral valve leaflet during diastole. Very similar to the wind that gets caught in a sailboat. By the way, the moment of doming also corresponds to the opening snap that you hear in mitral stenosis during auscultation. This is an example. On the left-hand side, you see a patient with a classic doming and mitral stenosis, and on the right hand, you see a normal echo. Look at the motion of the anterior leaflet. Compare the two. Here you see the typical bulging motion of the anterior leaflet, while the leaflet opens completely normal here in this normal patient. Remember, you can best see the doming motion in a parasternal long axis view. Here's another example of a patient with doming of the anterior leaflet, maybe not as much doming as we saw previously. We have a reduction in the opening, and here we have an example of a patient who also has a reduced opening of the mitral valve, however no doming. This patient does not have mitral stenosis, but he has a dilated cardiomyopathy with a myopathic motion of the mitral valve. So compare the two and see the difference. Doming here, no doming. Both valves have a reduction in the opening. Aside from doming of the mitral valve, I also want to draw your attention to other features that you will find in mitral stenosis. First of all, fusion of the commissures. You see, the mitral valve does not open all the way, but there is fusion here of the anterolateral and also of the posteromedial commissure. We also see very thick tendinae. We have thickening of the subvalvular apparatus, which also involves the papillary muscle. Furthermore, we have thickening of the leaflets, which are usually more prominent at the tips, but can also affect the entire valve. And especially in older patients with mitral stenosis, we find secondary calcification. Don't only focus on the mitral valve, but also take a look at the aortic valve, for example. The aortic valve is often affected with rheumatic heart disease, and you will find a thickened valve and pathologies such as aortic stenosis or aortic regurgitation. Because rheumatic fever also affects the myocardium, remember it's a pancarditis, expect to see a reduction in left ventricular function in some patients. And because we have an elevated pressure in the left atrium, we often see, or it's actually part of the disease, that we see an enlarged left atrium. And also expect to see pulmonary hypertension and right heart problems. We already saw this clip when we talked about doming of the anterior leaflet. But now I want to draw your attention to the aortic valve. You can see a thickened valve and doming. So we also have doming of the aortic valve, and this patient probably has at least mild aortic stenosis as well. Here on the right hand side is a patient who has mitral stenosis, no question, but he also has a reduction in left ventricular function. So this patient probably had a rheumatic involvement of the myocardium. Here's a patient with a very large atrium, again mitral stenosis, and also an enlarged right atrium. Take a look also at the shape of the atrium. It's more round, and we have a bulging of the interatrial septum to the right. We talked about that already when we talked about the heart chambers. This means that we have an elevation of left atrial pressure. And finally, this is from a patient who has mitral stenosis. We see that this patient also has pulmonary hypertension, very severe pulmonary hypertension with a velocity of over 4 meters per second. So, as you saw in the examples, very frequently we also have other valve pathologies. As a matter of fact, only 25% of patients have isolated mitral stenosis. More patients have mitral regurgitation in addition to MS, and aortic valve pathologies, for example, aortic stenosis or regurgitation in addition to mitral stenosis. And approximately 5 to 6% of patients also show pathologies of the tricuspid valve. If we take a look at the severity of AR, we will find that most patients have moderate to severe AR. Here's another such additional valve pathology, tricuspid stenosis. You see the turbulent inflow into the right ventricle, and tricuspid regurgitation, which is also significant. The patient also has mitral stenosis. And on the right-hand side, you see another problem, a patient with a thrombus in the left atrium. Patients with mitral stenosis are at increased risk of thrombus formation, first of all because they have a stenosis and often slow flow phenomena in the left atrium, but also because they frequently develop atrial fibrillation. So this is what we found in the literature with respect to the risk of thrombus. Well, systemic embolism is very frequent, 20% of all patients with mitral stenosis. Only 20% of patients are in sinus rhythm, and spontaneous left atrial contrast is a very frequent finding which occurs in almost half of patients. So you have to consider these facts both when you perform echocardiography, you have to actively look for a thrombus, and you also have to consider this when you treat patients. You have to think about anticoagulation therapy. Back from bench to bedside, here is a patient who actually has mitral stenosis. So now I want to show you how to evaluate a patient with suspected mitral stenosis. I'll tell you more about the patient as we go along. The first thing, we'll do a parasternal long axis view. Now just forget about all the other findings in this image and we'll just focus on the mitral valve now. What is important in this patient is to look at the anterior leaflet and ask yourself the question if there's a doming. So I'll try to optimize the image here. So you can see there is no doming, but there is some degree of reduced opening of the mitral valve. What is apparent just by looking at the parasternal long axis view is that there's a lot of calcium, that there's a calcified annulus here, but it's also nice to see that the posterior leaflet and the anterior leaflet, even though they're thickened, are still mobile and that they open. So when we add color, we can see some turbulence, but the turbulence is not very significant. There's just very little proximal flow acceleration, and there is some aliasing within the valve. So this is also an important clue. The next thing I'll do is I'll just turn to the short axis view and we'll look at the mitral valve. So this view is very important because you can really appreciate the degree of calcification. You can see that the posterior circumference of the annulus is calcified, not as much the anterior circumference where there's actually almost no calcium or little calcium, and that the valve itself is opening quite nicely. The opening is reduced. We can even do some form of planimetry here. So very difficult to see the contour. I don't know if I'll really take this for granted, but it will give me at least some clue as to what the opening area is 1.5. Okay? So this is just some morphologic aspects. And now we'll do some quantification. The first thing we'll like to look at is the mitral valve signal, the inflow signal. So we'll put the continuous wave Doppler spectrum across the valve. We could probably get a better signal if we really use the 2D color to guide us. Okay, this is a better signal. So the problem we have here, we can see that immediately, is that the A wave is taller than the E wave. So we have impaired relaxation, some form of diastolic dysfunction, and in this setting, we cannot use pressure half-time. So this will leave us with the question, what is the mean gradient? And I can do that by doing planimetry of the mitral valve, inflow. Okay, so we have a mean gradient of 10 millimeters mercury, which is elevated. So the patient does have some degree of mitral stenosis for sure. So we come back to the 2D image. Look at the color again. We do see the aliasing here. We can see the calcification of the annulus. We see shadowing of the annulus. Again, shadowing of the annulus, but still fairly good opening of the mitral valve. So if you put all this information together, the morphology, the mean gradient, we can probably come to the conclusion that the stenosis is certainly not severe. I would probably say mild to moderate. And that we also know that the reason for his mitral stenosis is not rheumatic heart disease, but it's annual calcification. This patient was on dialysis and then received a kidney transplant, and we see those degenerative changes very often in patients with kidney problems. Okay, so this just gives you a bit of a feeling how we go about in a situation where a patient has diastolic dysfunction, and we can't use pressure half-time to quantify, and where even the mean gradient is sometimes difficult to interpret, and also planimetry is not as easy. Now we'll image a patient with a known mitral valve pathology. So we'll optimize the peristernal long axis view. And I think it should be apparent by now what the diagnosis is, because it's quite clear to see that the leading problem here is doming of the anterior mitral valve leaflet. This clearly is a patient with rheumatic mitral valve pathology. But let's look closer at the morphology of the mitral valve. I'll try to optimize the image here. Okay. If we look at the leaflets, we see that it is especially the tips of the leaflets which are thickened. The body and the base of the anterior leaflet is fairly mobile, and also the tip of the posterior leaflet is thickened. Then what you can do is you can just tilt the transducer caudally and anteriorly, and thereby look at the subvalvular apparatus. So this is the tendonae, the papillary muscles, and you can appreciate the thickening of the subvalvular apparatus as well. This is a typical spectrum of changes that you see following rheumatic heart disease, with doming of the anterior leaflet as the leading problem in this patient. Now we'll look at the patient in a short axis view, which is very important because we want to look at the opening of the mitral valve. We have to look at exactly the level of the mitral valve, which is approximately here. And then in early diastole, we can freeze the image. Okay? And then we can quantify the mitral valve area. So we'll just trace the area here. And we get 2.8 square centimeters, which is almost a normal opening area. So from the planimetry, we do not have the impression that the patient has significant mitral stenosis. We'll just repeat that to be sure that we really have a good value. And you should actually average a few values to really get a good measurement. And 3 square centimeters again, because this confirms our primary impression that the mitral valve opens quite nicely. This is actually also appreciated when you look at the peristernal long axis view. You see that there's doming, but the valve does open quite nicely. But coming back to this view, I also want to show you the color, simply because we want to see if there's turbulent inflow into the valve. Not really. There's some degree of regurgitation. We'll come to that later. But certainly the patient does not have much turbulent inflow, which fits very nicely to a rheumatic stenosis, which is not severe. But to get more quantitative information, we have to look at the apical views. Okay. Bisschen mehr zu mir drehen. We'll just turn it more on the back. Dankeschön. So, again, the morphology is important. Try to focus on the mitral valve now. Doming, thickening of the valve, but good mobility. Put the color in here and concentrate on mitral valve inflow. So we'll try to get a good candle flow or candle flame signal here and use that as a guidance to put the continuous wave Doppler through the valve. We'll put the focus point in the valve as well. And here we have the spectrum. So the first thing we'll do is we'll look at the pressure half-time. Try to see exactly where the maximum velocity is and go along the contour. You don't need to go all the way down. It's just sufficient to get the angle. So we have a pressure half-time of 97 milliseconds, which is almost normal. And this corresponds to a mitral valve area, which is 2.3. Again, a mitral valve area which is far above 1 square centimeter, meaning that this patient certainly does not have significant mitral stenosis. The next thing we'll do is we'll take a look at the mitral valve curve and try to quantify the gradients. So I'll contour the curve here now. And look at the mean gradient, which is 4 millimeters mercury, practically no gradient. So in summary, this patient has typical rheumatically affected mitral valve with rheumatic stenosis and with very low mean gradient and a mitral valve area above 2 square centimeters. So it's certainly only mild. This chapter will serve as a backbone for the diagnosis and for the evaluation of patients with mitral stenosis. Keep in mind that every patient looks a bit different, and if you want to see other patients and different variations of mitral stenosis, don't forget to go to our Atlas section. We have a large database of cases of patients who have mitral stenosis.